Welcome back to the second part of this lecture. In the first part, we were looking at end-of-life decisions as a whole, different types of concerns and questions that may arise as someone ages or becomes ill or possibly disabled. What I'd like to do in this second half of lecture is really look at specific types of advance directives. The words advance directives are really a general term used to refer to this compilation of legal and medical documents. These are the types we'll explore in lecture today. We'll look at a living will, a general power of attorney, medical power of attorney or DPOA, which stands for durable power of attorney, financial power of attorney, and then conservatorship or guardianship. These are listed in order of least restrictive to most restrictive, or the most straightforward to the most complicated in terms of accessing or appointing. As we look at these different types of documents, it's important that we understand some key terminology. When you read these legal documents, many sound like a contract, and the wording can be very formal. But what do those words mean? Here are some basics. The principal, the patient, or you, basically the person who is appointing an agent to act on his or her behalf. This may be the patient you're caring for who has advance directives, or it could even be you if you're wanting to get them drawn up. Then we have the agent. The agent is someone who has the power or authority to act as the representative of another. In other words, this is the person that you appoint or give permission to make decisions on your behalf if you become incapacitated or unable to make decisions yourself. The word durability for advance directives means that the agent is authorized to handle the principal's affairs in the event that he or she becomes incapacitated. So say that the person, or you for that matter, get in a bad car accident and you have brain damage, or maybe you develop Alzheimer's disease as you age. Having a durable power of attorney allows that person to be able to make choices on your behalf. This is stronger and holds up better legally than just a general power of attorney. Successor agent selection. This is a term that really refers to the fact that the principal can appoint another person to be their agent if the first agent becomes unable to act on their behalf. So say the first person you appoint as the power of attorney, maybe they die, or they're also injured in a car accident when you are, or they're out of the country when you have something tragic happen. This allows you to have a sort of backup proxy decision maker just in case. And mental competence. This has to do with ensuring the principal is of sound mind and is capable of making decisions. If someone is mentally incompetent, such as someone suffering from end-stage dementia, they would not be in the right state of mind to make a decision appointing someone else to make decisions for them. Ideally, in these cases, the decision would have been made earlier, before the person is no longer mentally competent. However, this doesn't always happen, and for those of you who have worked in long-term care, you've certainly seen those events. So let's start with a living will. A living will is used to inform loved ones and healthcare team members of the patient's wishes about medical treatment when that person is no longer able to speak for him or herself. It is a legal document stating a person's desire on what measures should or should not be taken to prolong life when his or her condition is terminal. This may involve withholding or never starting life-prolonging treatments, or it may involve removing life-sustaining treatment that has already been started. Every state is a little bit different regarding requirements for acknowledging and upholding a living will, so it's always a good idea to be informed and educated on your state's laws. Some living wills use very generic language, and they often say something about not wishing to have life-sustaining measures in the event that one becomes incapacitated. Others can be very specific, though, and it allows you to specify whether or not you want specific interventions, such as CPR, intubation and mechanical ventilation, artificial nutrition, such as through an NG tube, a G button, or gastrostomy, or artificial hydration, like IV fluids. Some even get as specific as whether or not they want to have oxygen administered or not. This is your place to really be specific about what you're okay with and where you want to draw the line. I'd like you each to take a moment to push pause and think about what you would want or what you would not want to have happen if you were injured or ill to the point where your recovery was highly unlikely. When you're finished, go ahead and push play again. A general power of attorney document is one in which you as the principal appoint your agent to act on your behalf in a variety of situations. This may include health care as well, but oftentimes focuses on financial responsibilities. You can also be more specific in outlining who can do what, such as who could manage your rental properties that you might own, who could handle any other investments, or so forth. The general power of attorney is a good start, but most doctors and most lawyers recommend that people have a durable power of attorney instead. Now, you can have this power of attorney or durable power of attorney in one document that might contain medical and financial pieces as well as a living will, or you can have those separate, maybe a living will separate, as well as separate power of attorney for finances and for health care. So this durable power of attorney for health care, in particular, we'll look at first. This is the document that appoints an agent to make medical decisions on your behalf, but only when you're unable to do so for yourself. A durable power of attorney for finances could be the same person, or you might appoint a different person, and their responsibilities are to handle things related to financial matters. When you put a durable power of attorney into place, you have to be awake, alert, and able to comprehend the forms that you are executing. In other words, you can't suffer from significant dementia, psychosis, or any other delusional state. This is important because it prevents people from taking advantage of those who are sick, elderly, or dying. The person appointing the power of attorney has to know what's going on and to be able to pick that person themselves. Again, the powers granted to that agent could be limited or expanded depending upon the wish of the person executing the form. Guardianship or conservatorship is the most restrictive alternative, and you want to try everything else before you end up in court. Most of the time, the person can appoint a power of attorney, but what happens if they don't have one, if they never did that, and then family members disagree with each other or disagree with the medical team about what to do to care for this person? The courts will appoint a guardian to represent the best interests of the patient, and this is not only time-consuming, but it's also very expensive. The court may be very specific about what areas the guardian or conservator has a right to make decisions in, such as just health care or just finances. Also, it's good for you to know that a hospital could instigate a guardianship proceeding if a patient is incompetent and has no apparent caregiver to make medical decisions or care for them upon discharge. The guardianship expires when the principal or the patient dies, meaning that the guardian would then no longer have access to their medical records. That power would then pass on to the executor of their estate. In some cases, the person may have a power of attorney and a guardian because maybe the power of attorney couldn't fulfill their duties for some reason. In these cases, the guardian trumps the power of attorney. In other words, the guardian has more power or the final say over a person who was appointed as that power of attorney, and that's important to know. In emergency situations, paramedics are legally required to start life-sustaining measures, such as CPR or ambubagging, unless a do not resuscitate order is provided to them. It sounds simple enough, right? But it's pretty complex. How often do people have a DNR or a DNI, which stands for do not intubate, order with their doctor's office, but it's not actually on them personally? I mean, some people code in a hospital or a clinic, but many times people's hearts stop beating when they're out and about in the town, in the community, doing things that people normally do. It's not likely that you'll have your DNR paperwork on you, and thus the EMTs would do whatever they could to save your life. This is why it's very important to have some type of card in your wallet or purse, or even an ID bracelet or necklace, like we see above, that clearly indicate your wishes. When I think about this, I think about a good family friend of ours who died this way. It was one of my grandma's best friends, and she was living in an assisted living facility. She had talked with her doctor, and they agreed that she would be a DNR and did not wish to be resuscitated in the event that she went into cardiac arrest. Each resident with a DNR at that facility had it marked on a piece of paper that hung from a magnet on the front of the refrigerator in their room. Now, for whatever reason, her paper was not there, and she stopped breathing. The ambulance was called. Again, I'm not sure why, since it should have been documented in her chart at the facility, but nevertheless, the ambulance was called and they initiated CPR. Her heartbeat came back, but she never regained consciousness. She was in a persistent vegetative state, and the family had to ask the doctors to remove life support that she never should have been placed on in the beginning. It was very sad and traumatic for all involved. And to make matters worse, this same family experienced another tragedy just a year later when another loved one was declared brain dead after an accidental fall and had to be removed from life support. These types of situations, while they may sound extreme, are actually quite common and just reiterate the importance of not only talking with others, but documenting your wishes in writing, putting that information in a place that people know where to find it and it's visually available, so that everyone knows what to do or not do in the event you become unable to make that decision for yourself. These issues can get really complicated. Here are some common questions that people ask related to advance directives. Can my spouse or partner make decisions? There are lots of possible scenarios or complex family dynamics that could be happening, but to make a long story short, the answer is yes, sometimes. Typically, if there is no power of attorney on record, the healthcare team can turn to others to consent for treatment. This first includes your spouse or legal partner. If there is none, then they would look at your adult child, with a waiver and consent of all other qualified adult children. If that couldn't happen, then they'd look into what the majority of your children would say. If you have no children or no spouse or partner, then they may ask your parents if they're alive. If none of the above are options, they could ask an individual clearly identified to act on your behalf before you became incapacitated. They could ask your nearest living relative or even a member of the clergy. Keep in mind, though, that not everyone will always agree with each other, let alone the medical team. So in cases where things get complicated, you may well see the hospital asking the courts to appoint a guardian or conservator. Will I receive the same treatment in the emergency room if I have advance directives? Quite frankly, it all depends on what you're being seen for. If you have a DNR on record and your heart stops, then the ER will not initiate CPR. If you have a living will on record, then the hope is that the ER doctors would follow your request and either withhold or withdraw life supportive measures. Many people worry, though, that they will be treated poorly or they will receive substandard care, and that is not the case. They're not going to refuse to treat your head injury from a fall or your infection just because you don't want life support or CPR. Those aren't even related. They will tailor your care toward what you need and what wishes you have expressed. You'll still get pain medication. They'll still try to manage your symptoms. This gets more complicated when no advance directives are in place, though, in which case the ER doctors will likely do whatever they can to keep you alive. So if they don't know that you don't want that, they're probably going to do that. They're probably going to hook you up to a mechanical ventilator or start other types of life-sustaining measures if they have no reason to think otherwise that you wouldn't want it. So again, it's important to let people know what your wishes are. Does this indicate code status? Your advance directives can be very general or they can be very specific depending upon how you've executed them. Therefore, it's always best to clearly indicate what your code status is. Do you or do you not want to have CPR done in the event your heart stops? Do you want to be intubated if you are unable to breathe on your own? Remember, though, your code status supplements rather than replaces advanced directives. So it's not enough just to say that you're a full code or a no code. You really need to have that as just one component of that advanced directive package, if you will. What if the patient is no longer able to make their own decisions, but they have not executed any forms, so you don't have any advanced directives? And this brings us back to the earlier question and the list of people that the healthcare team may consult for information or decision making. If the family can agree, it's fairly straightforward. But if there are big disagreements between family and the healthcare providers, the courts may need to get involved. Will my advance directive be followed in another state? Again, there's no easy answer here. In most cases, yes, most states will honor your advance directive if it was signed in a different state. But it's not a guarantee, though. So if you live in 2 states or you spend a lot of time in more than one state, it's recommended to have one drawn up in each state that you live or spend significant time in. Finally, who can witness my documents? Each state may have varying laws, but by and large, anyone can be a witness so long as they are not one of the people that you're trying to appoint as your power of attorney or a guardian. Okay, so if you wanted to make your spouse your power of attorney, your spouse cannot be one of your witnesses. It can be anybody else. I mean, it might even be, someone that you don't know who happens to be there. Maybe it's the physician or nurse. Maybe it's is a random person. Maybe you're at the bank because you went to get a notary public to sign because some documents need to have a notary stamp and signature. So you have somebody else at the bank be your witness. That's fine too. It just can't be that person that you're wanting to give decision-making powers to. And they do that to protect the patient so they can't take advantage of you or try to force you to kind of hand over your decision-making when that's not really what's in your best wishes or interest. Let's look at some clinical suggestions as well. It's helpful for us to know what to do or where to turn when these types of situations arise. First of all, whenever you start working at a new facility or for a new organization, find out what their policies are as far as advanced directives. Know where to look for information, who to go to with questions, and what to do as things come up. You can always check a patient's chart to see the copy of their advanced directives if they have one that should be on file, either as a paper copy or as part of their electronic medical record. You can talk with your patients about their wishes. Certainly, if they've filled out the forms, they're probably expecting someone from the medical team to at least mention it and make sure they understand the patient's wishes clearly. If you're caring for patients and they voice their wishes to you, but they don't have anything on file, then you need to document that in their chart. Write down exactly what the patient said in the words they used. If they want advanced directives but haven't done so yet, then document that and make a referral to nursing or social work so you can get that process started. It doesn't have to be that complicated, so you should be able to help facilitate that for patients when they request it. Then you need to realize that patients have the right to revoke their forms for any reason, whether in writing or even verbally. Things happen, and patients of sound mind have every right to change their wishes and documents. Document this in their chart, and if needed, refer them to someone who can help them change their documents if desired. And certainly, if there are changes made and you document that in the chart, make sure you report that on rounds as the next shift comes into place, and make sure their physician is informed as well. Okay, we've looked at some of the bigger types of advanced directives, such as living wills and durable power of attorney, even guardianship. But what else do we need to know and understand about end-of-life decision-making? Well, organ donation can be a really important part of planning ahead. Not everyone wants to be an organ donor, and in the United States, not everyone is required to donate their organs. This is different in other countries. That being said, many people still want to. Much of it comes down to personal preference, but may also relate to one's religious or cultural beliefs and values. In some faiths, organ donation is not allowed, and it's important for that person to be buried or cremated whole and with all their parts for the next life. For other people, their faith guides them in wanting to give life to others through donating their organs when they die. There is no right or wrong here, as it's a deeply personal decision. There are guidelines and laws that guide what organs can be donated, how donors are placed on the transplant waiting list, and what parameters must be met in order for that organ to be transported and then transplanted. The Uniform Anatomical Gift Act sets a regulatory framework that guides these practices and also regulates body donations to science, medicine, and education. Of course, how you die impacts whether or not you're actually able to be an organ donor. For example, most organs need to be kept alive in order to be harvested and transplanted into another person. In many cases, this means that the person is kept on life support just long enough for their organs to be surgically removed and taken to be given to save someone else's life. So in order to save someone, typically another person has to die. And that makes sense though, because we wouldn't want to take organs from living healthy people, with the exception though of kidneys or sometimes pieces of liver, that is. There are many policies and standards in place to protect the patient, whether that's a living donor, like in the case of a kidney donation, or the living recipient. Wills and estate planning don't deal with the healthcare side of things, but rather they have to do with all other kinds of financial matters, such as who manages or controls bank accounts, investments, life insurance policies, rental properties, college funds for children or grandchildren, and so forth. A will and testament, as it's called, is very different from a living will that we looked at earlier. Here, a will and testament is a legal written document that allows you to specify who gets what. Who do you want to have your house, cars, vacation property, mementos or collectibles, specific furniture items, jewelry, etc. If you have young children, who will assume custody and care for the children if you were to die? In most states, the testator, or the person making the will, must be at least 18 years old, 19 in Nebraska. They must be of sound mind. You have to have at least 2 witnesses and have voluntarily specified the contents of your will. So you have to make it your wishes known. You can't have your children decide who gets what and then they want you to sign it. You need to decide. Some states also recognize other types of wills. For example, say that you have a will that you wrote in your own handwriting, but with no witnesses. That's called a holographic will, and some states recognize those and others do not. An uncupative will is a verbal will, so you're saying out loud to at least 2 people what it is that your wishes are in terms of how you're going to distribute personal property. Okay, so that's verbal, not written. Again, that may or may not be honored depending on the state law. Ultimately, estate planning is usually something that someone does in preparation. Oftentimes, people will meet with their financial advisor or their accountant or their lawyer to decide how best to invest their money or allocate their assets. And this can include a will, but doesn't always. People will usually appoint an account executor, which is the person who will manage all of their financial needs if they're unable to or after they die. If you die without making a will, a court will distribute your property according to the laws of your state. This process is known as intestate succession. It gets complicated as there are various rules and laws, but that's just the basics that I want you to know for that the court will intervene and help decide how to distribute that. That being said, if you have property designated to others in a living trust, which is yet another type of document, those beneficiaries directly get those assets or property. But if they're not included in a will or they're not included in a living trust, then it may have to go through probate court to decide who gets what. There are many components to financial planning that go beyond just bank accounts or investments in stocks, bonds, or mutual funds. Here are some other sources of financial security that many people rely on at the end of life. Life insurance plans, either term or whole life, some of which pay dividends on the investment. Viatical settlements, which are an arrangement whereby a person with a terminal illness sells their life insurance policy to a third party for less than its mature value in order to benefit from the monetary proceeds while still alive. So example, maybe you have a rider on your policy that says if you are diagnosed with terminal cancer that you can kind of cash in or sell part of that policy early to use part of that money to pay for your cancer treatment, and then you wouldn't get that benefit after you died. We also see Social Security, which is based upon the earned income over their lifetime contributions from either themselves or their spouse. Veterans Administration benefits or payouts for disability incurred. And then we see employer pension plans where they get a set monthly income based on the number of years of service or employment for that same company. In the past, we saw employer pension plans set up for places like the railroad or factories where people work for 30, 40, or 50 years. Now, however, it's more common to see 401k investments and matches offered by employers, and that's the type of pension plan that's put in place most commonly. It's important to know, though, that just as these sources may supply a source of income during one's lifetime, many also offer money in the form of an after-death benefit. For example, if someone has life insurance, then when they die, their beneficiaries get that money. There are also survivor benefits through Social Security. Veterans have access to their own life insurance coverage and death benefits that go beyond much of what the public or civilians would have access to. As you can see, there are all types of decisions that people must make over the course of their lifetime and as they approach the end of life. The good news is that most of us are quite fortunate to have access to many valuable resources. We can consult with our physician, our lawyer, a religious or spiritual leader, our friends and family, even an ethics committee if we needed to. But realistically, we have to realize that not everyone has access to these resources, though. Not everyone can get to the doctor very often. Certainly not everyone can afford a lawyer. So part of our job will be serving as an advocate for our patients and helping to connect them with resources that are affordable and accessible to them within the context of their own life. As mentioned earlier, each culture looks at life and death in its own unique way. While there are commonalities, there are also very specific preferences about things to do or things to avoid, and it's important that we take the time to figure out what each patient wants. It may be very different than what our wishes would be, and that's totally okay. It's not our place to push them to do something or not do something. It's not our role to convince them of anything, or even to judge them for the choices they make. Everyone is doing the best they can in these challenging moments, and we want to respect our patients and their families and offer our support. We want to help their dying process be as calm and pain-free as possible, and that includes honoring their wishes to help facilitate a peaceful death. As a healthcare provider, we have responsibilities to try to honor and uphold our patients' wishes. We also have responsibilities for our own personal affairs. For our own planning purposes, it is important that we take the time to think about, discuss, and document our wishes regarding medical care, financial affairs, and so forth. Once we have these forms created and witnesses, and again, in some cases you might need a notary, then we need to store them in a safe place. Provide family members, attorneys, or executors with a copy of your documentation so it's clear what you want done, who will handle what types of decisions, and so forth. I also store a copy in our safety deposit box, and then I make sure that my parents and siblings know where to find the key. And then, anytime you have big life changes, or maybe no big changes, but just once a year, it's a good idea to review your advance directives. My husband and I have changed ours in the past based upon family relationships, as well as where we lived at the time. There are many reasons you may want to revoke or change your documents, so be sure you know where they are located and then get the updated copies of your advance directives to family or others who need to have the current information. As you work on completing your own advanced directives for this week's assignment, be sure that you're also thinking about what's going to be the right choices for you. What are your values? What are your wishes? Are there any religious beliefs that guide your practice? How do you define life, living, and quality of life? What is most important to you at the end? Who might you consider appointing to make medical decisions for you? What about financial decisions or arrangements? Take some time to think about these, and I'm very excited to see what it is that you put in place with your advanced directives that are due at the end of the week. Of course, if you have any questions about lecture or the assignment, be sure to let me know, and I'm happy to help. Thanks for listening.